Okay, colleagues, shall we recommence? Hope you had a few minutes casual. We'll move on the biannual staffing report 171. I will again, forgive me colleagues, be a bit fussy with the timing, etc. I'm assuming they'll ask the people providing the report to say the same thing. You've all received the report, you would have all read them. So I don't expect the people giving us the reports to take us through the report. Just get to the main point. So item 171, biannual staffing report, Chief Nursing Officer, please.
Thank you, Chair. So this biannual establishment report is here so that we comply as a board with national quality board guidance that our nursing establishments and units are reviewed, and they are triangulated in line with our risks, acuity, and making sure we're keeping our patients safe. So as the chair alluded to, I'm going to take this report as read, and it comes in net twice a year, just to give assurance to everybody. Every area of highlight is that within the review, medicine, care group, surgery, co-clinical, and integrated communities made no changes to the establishment. However, surgery is looking to restructure and mitigate associated with the on-call theatre, and I think Donna talked about it. The theatres within maternity, but there's no financial impact to it. There is within the women and children care, there is a request for uplifting certain numbers following their workforce assessment, but we cannot, our report is not there to sort of make a case for that. So they've been advised to do a business case, which goes through the financial government. It should be effective. Thank you.
Colleagues, any questions, any issues? Aaron?
And just one information, thank you. And I absolutely understand to have a further point about this not being the place for implication of being managed separately. But if there is a suggestion that we may need 20 additional staffing in women and children, are there any safety concerns that we need to be cited on associated with that, or are they really?
There are no safety concerns at all. They're being mitigated, but however, the Associate Director for CYP has done kind of a workforce review in line with pediatric guidance to see if our numbers are in line with those pediatric guidance, and that's where that gap has been kind of found. But otherwise, currently, we are mitigating with the stuff.
Just a quick one, thank you, Mike. I appreciate you doing a lot of work with that. Programs and apprenticeships and things like that. But I was also wondering what we're doing to try and get already out to big ways go supporting their colleague feet, their return to practice really. It's a big outlay, isn't it, people?
Yeah. So at the moment, John Westwood, the Deputy Chief Nurse, is working in regards to sort of recruit, retain, and develop. What I'm doing is I'll highlight that to see how we can improve that into our workforce reviews and growing our own women. People retired, we may want to come back. I don't think we have focused on that, but I'll pick it up.
And not just retirees, people that have left for families or other care and commitment are quite often then established in the area. So potentially there may be a less attrition rate. I don't know. Thank you.
Colleagues were asked to consider this report. We've given it due consideration. Okay, thank you. Thank you, Chief Hurst. We'll move on then to item 172, Chief Exec. Provide a collaborative update.
Definitely, Chair. Three key programs work are referenced in my CEO report. We've got a deep dive into the one LFC program later on this afternoon. The rest of the key work programs like the pathology collaborative, youth and collaborative will feature in the forward work plan from here.
Questions, issues, people wish to raise? That's fine for the update. Okay, you know those. Yeah. New hospital program Q3 report, Chief Operating Officer.
Thanks, Chair. Nothing that I wanted to pull out specifically for the board, other than to note the point made at paragraph 4 around governance, covered in the next agenda item. The work is ongoing and significant around land acquisition for the site, and that's constant no further detail at this point. And what ongoing with the ICT around the machinery that would underpin public consultation. I think we're arrived at that point. Take any questions?
I think we've got governance structure as the next item. This is still update on current progress. Happy to accept.
Yeah.
We'll move on then to joint report, Chief Operating Officer and the Company Secretary, the new hospital governance structure. Please note the audit committee has considered this report and recommended. Tony,
Yeah, absolutely. Thorough discussion.
who's gone first?
Oh, sure. Thanks, Chair. And thanks to Paul for the significant work getting us to this point of paper and to the other committee. So again, I just want me to paper out, but it is important to note that this is a significant shift in the governance of the new hospital program trust. And so we've discussed previously as a board that the need for and the specific set of governance in the strategic outline case phase then had to change necessarily as we get now towards the business case phase and change in the middle phase. And so this paper describes the rationale for that. It then gives the detailed potential reference for what we're very deliberately calling the UHMB New Hospital Project Committee. And there will, in our colleagues in the teaching hospital will have a similar board and the ICE support group and the new hospital in the ICE set the board subcommittees for the new hospital project and the trust and program in the NCB. Hopefully, the reference is straightforward and listed from several trusts that have done this or are doing this and that's recommended to the board.
Anything the Company Secretary is required?
Yeah, the only point just to draw the board's attention to is a point that Sarah Rees made, and it was raised at the audit committee, which is this is a fairly unique project. Because of the SRO, have significant decision-making responsibility for the delivery arrangements. As usual, we select for significant matters. For this particular committee, we envision will be also bring that to your attention as we get more information and we can see we visit that actually this particular committee.
And Tony, that issue has been considered by audit.
Yeah, it was as I said, thoroughly discussed, and it put that balance between giving the trust sufficient executive oversight of the project, but being part of the system where there will be some conversations on the system both.
Happy to approve, colleague. Yeah, thank you. Chief Medical Officer update, Cameron. Thank you.
So, thank you, Chair. I'm going to address the 175 agenda item. There are 3 papers, so I will take members have read all the 3 papers. I will take it one by one. The first one is the research and development update. As we all know, research is very crucial for any organization, especially attracting colleagues. So just going through salient points, actually our research and development department is actually attracted quite a lot of study portfolios that's actually growing in the last 12 months. We've got 11 studies opened and we've got around 30 new studies in the setup. That's a good thing. And our team is actually looking in terms of new opportunities, especially oncology, respiratory, diabetes, and rheumatology. And as you all know, the new oncology is opened, and there is the possibility that opportunities in terms of especially the pharmaceutical trials, the possibility. And we've got a research and development lead who works with the team, especially to work around the operating processes and quality measures, which is actually very essential in terms of running quality trials and to have a proper oversight for that. And also there is some concerns around the working place. I think good news is, I think after this report has been written, we got allocated space in our line, especially the old aerodynamic space. So I think that's a good news. And also there are some concerns around the reserve funds available currently within the research development team. I think because there are some concern about whether it can be used for something else, because I think that's looked into. So I'll take, is it okay? I'll take the questions there then. Chair? Yeah. So coming into the next paper, again, it's a GMC training survey report of 2023, which is actually in page number 571. So GMC survey actually is a monitoring tool for doctors in training. So it tells the quality of education and training for each placement provider. So this report has been presented to People Committee as well as NHSE Quality Review Committee. So that's already happened. As with all trust, so there will be areas of improvement, as you can see in the report, and this area of deterioration. This survey reflects not only just the post, which actually gets the trainees in, also the program itself. So there are quite a lot of variations. So when trainees feedback, that will be multifactorial, because if you look into trainees posting itself, as well as the number of trainees, the level of training, as well as the number of trainees in a training area. So that may affect their feedback in those sort of positions. But that doesn't trivialize any of those. We take it very seriously, any of those feedback. But GMC has not identified any specific risks. So, but NHS quality team actually wrote to us in terms of what are the improvement areas and what are the areas need to be monitored. So it actually got a scale in terms of 0 to 4. We are at monitor stage 1, which is actually a minor concerns, which can be monitored locally. And we already submitted the plan to NHS quality team. What is our plans to implement as well? So our DME, especially Dr. Bukhari, as well as the other department teams, actually works very closely with the NHS. Previously, it is AE, now the NHS workforce training and education. So that's that's the thing. So that actually oversees our improvement journey. So that gives us an additional assurance as well. So I'd like the board to consider this report. And also at the end, what we have got the Guardian of Safe Working report, which actually in the page number 579. So Guardian of Safe Working actually provides assurance that doctors are working, hours are safe, and also gives our trust reporting in contract of 2016 terms and conditions. So this paper, this doesn't give you the full picture in terms of what's happening, but this actually main intention of this paper is setting out how the reporting system arrangements and their changes. So board should receive the Guardian report quarterly, but in the future it will go to the People's Committee and it's scrutinized that any matter which is of concern or assurance, that will be escalated the 3A report in People's Committee. And if the Guardian has got serious issues which have not been addressed, it can come as an exceptional report straight to the board next meeting. So this is the salient points. Just need some time to take.
Can I just clarify for the Guardian if they working report that we are now saying that it will just be the annual report that will come to trust board, everything else will be delegated to people committee. But that annual report will be the Guardian if they working for the Director of Education. You have contract requirement under the terms and conditions to present around the education section report.
Yeah, just regarding the R&D report, so thank you for presenting this week. I was got a question about the R&D report. Firstly, I think it's really positive about the health of R&D with the organisation. The fact that there are 30 projects that sort of like in the pipeline, so to speak, one of the 12, 13 that are underway. The covering paper actually just makes the comment about the requires the trust board's support to address that. And you gave a bit of a feedback. Does that mean that that has now been solved, or are there still issues that you require the trust boards?
Yeah, that's the place that's been solved. It's actually isn't that not writing paper.
Yeah.
But I think, yeah, it needs some support in terms of making that place better. I think they're looking for the charity partners in terms of.
Oh, I mean, I'm just to your assurance that obviously the places being identified, it will actually be equipped for the. I think that's just the reassurance.
Lines going up, so, and, Scott, Adrian, Karen.
Give the assurance that every paper that comes has got to ask for accommodation, regardless of whether it's said for support or with the capital pipeline and the risk assessed by a multi-professional team scored on capital is oversubscribed by a factor of 9 to 1. And so it's risk assessed. So it will be in the file for risk assessment, but that's not an assurance that it will be prioritized.
Well, we are in the position now that actually the last report, there was no accommodation identified whatsoever. So we're now in a position where we've got an identified place. It's just a question about what the conditions we like. We some of the people work.
If I just guide the board, it's not the board's job to allocate resources.
Absolutely.
Executive roles, so let's not get bogged down in it. I understand what he's seeking there, you're seeking assurance about the process. Yeah. Thank you.
Thank you, Jen. Thank you, Katie, for the report. I just wanted to pick up on some of your comments about ensuring that the study portfolio contributes towards attracting the right calibre and candidates to come to our area and be helping them build their career and the flow of that. It would be really helpful in a future report, although we're seeing an increase in the number of opportunities and study programs, just to understand how we perform in both the regional and national level and or longer term. Do we have a target or longer term in terms of the number of study opportunities that we're trying to create across the trust driving?
Currently, I don't have specific that I can get back to that. I think you're absolutely right. Our research is very crucial in terms of not only recruiting, retention of the staff. So that gives because there are different people who have got a academic mindset. They'll actually want to do some research. There's no that they will come to some organization. I think very crucial. I can get back to the team now.
If I can just intervene as well, just a suggestion. There's some really exciting discussions going on, as you know, with medical education, Lancaster University at the moment. Equally exciting between the chief nurse and Cumbria University. We're just exploring the model of a clinical faculty for the trust, which would then help us to coordinate the research and growth of research. I'm just wondering whether the board would be interested in perhaps in autumn, given a plenty of time of running, if the chief nurse and the chief medical officer will do a development session with the board on what's going on with the R&D and enterprise across the trust. So the board has a broad helicopter view of the activity. I look for the chief nurse for advice.
Yeah, that would be welcome, because talking to sort of Dave, we've already started mapping to see what we are doing and the number of the business that being undertaken in terms of your understanding and your funding, and that's going to be shared with you.
That would be. Thank you.
took an autumn session. Look at that and the next week. Thank you. Thanks, everyone. Eric?
Well, thank you, and thank you, KB. I have a question about each of the papers. I think the first one, though, probably is more related to what Mike's just posed. And my question was really this particular paper and probably this particular lens is focused around clinical medical research, and we heard about rolling it out, but I think there's a really strong case of we having a wider angle lens on research and development. So, for example, the conversation we had with Julia this morning, what is it that's driving that kind of board manager leadership improvement and everything that's happening in OD, the cultural improvement programme and the impact of our leadership development programme and so on. I think there's a huge opportunity to widen our lens, and we've decided as a board on a very inclusive approach to R&D. So I'd really welcome if we might be able to build that in especially. So comment more than a question actually. The second one about the GMC paper, I can see that there are really minor concerns to be managed locally, but there's a couple in there relating to obstetrics and gynecology and bullying and harassment. I just wondered, is the response to those being built in as part of the overall cultural improvement work around maternity? Are they being connected? It feels like it's similar themes.
So we won't have specific detail of that, and it's done in an anonymous way. But we are aware of the kind of interface issues in terms of how teams are interacting, and that is being picked as part of the broader work.
A good point, the training environment, the total environment we are looking at, so that there are some identified cultural issues which actually need addressed.
Connection is really critical. And then the Guardian of Safe Working, again, understand that and support that reporting and the reporting into the people committee. I just wonder whether we're making the most of an opportunity to triangulate any breaches around safe working practice and patients' safety, just to make sure that we connect that. Because I understand safe working practice and positive experience is absolutely critical, but actually ultimately it's how that impacts on patients. So are we going to triangulate that?
So all the incidents are taken through LRG because I sit in LRG as well in that. So anything will be correlated. What is the positive factors? So that we will be looking into those, and it will be picked up if there is staffing issues and other issues.
The other thing that is reassurance on this is that the systems that the chief doctors use to do usually and to make that available to all the doctors, whether they're dealing with trainees or not. But it has a section in there that actually knows has there been any patient harm associated with it. So they should be filling that in if there is, and that would be critical with the exception of course in that process as well.
The last one from me, KP, there's some concerns about the recent ring fence. I just propose that perhaps you could talk to our finance officer outside of the board to use the word concern. So obviously that has assurance issues for the board. So probably just see through yourself and the finance team that issue is resolved, so the colleagues don't feel those concerns. Okay, colleague, can we give that due consideration? Thank you. 176, please speak up, biannual report, good report. And the quality committee has considered this. Just before I bring you in, Chief Nurse, I'll have to chair the quality and it will escalate for the report.
Thank you, Chair. We've already touched on it. It's clear to provide an update on our approach to picking up and where we are in evidence and the principles picking up with the next. So I'll take the report. The only areas to which have within the report that people class is and at the moment within the speaking up. There's been a reduction in the number of people who are speaking up and not want to be identified. We go back and I comment on that document explored through people in culture, through transparency and the so much to look at how we can continue to support our staff to speak up without fear of competition. And the freedom to speak up that should be there. And
Just for clarity, just for opinion, the 100% compliance, our colleagues who have completed the freedom to speak up development program. It's not referring to 100% compliance with CPD.
Yeah, we did have a discussion about this at people committee, and one of the things that we said was we need to work closely with my team and the free speak up guardians and down as the kind of the lead manager for this is really about how we support the free speak up guardians. They don't act as post box, but they're able to signpost and transition concerns to the right process.
Because I know a lot of work being done here with the people speak up team. The other, there's a little bit of a stat there. 97 responses to a question about the vet feeling comfortable or secure or bullying or harassment free into trust. There were 97 respondents. 2 said that they were uncomfortable, which is round it up to about 1.5%, 2% if you wanted to round upwards. You've got 9,000 staff. If you then correlated or extrapolated that 97 to 9,000, it may mean probably about 180 staff may also be uncomfortable. So it's just an observation really around the stats refers to a survey group of 97, but that's only a certain percentage of 9,000, and then 2 out of 97 looks really good. But if you expand that across the whole batch, it'll be a lot larger, about 180 hours. And that's something probably that we want the people to speak up, to keep digging away at, just to ensure that actually it is a very small minority, rather than a larger minority.
Just a reflection, I think, on that last point, Chair. It's not just the responsibility of the Freedom to Speak Guardians to manage this process and promote it and dig into what the issues are. So we have something like over 10 different opportunities for colleagues to raise issues, concerns, or areas for improvement. It's a big part of our cultural development programme to make sure any colleague in any forum gets the opportunity to do that. So whilst the Freedom to Speak Up service is very important, it is only one part of, I guess, the culture that we've got in place, the framework we've got in place around speaking up. So one of my offers would be when we have a Freedom to Speak Up biannual report, it would be good to see in context, not just the Freedom to Speak Up service, but what we see in terms of colleagues speaking up generally for the board of reassurance.
Good clarification, thank you. Yeah, good point. Yeah. Okay. Any other points on this paper? Very well written. Okay, we accept them, we considered it. Thank you. Then we'll move over, still yourself, Chief Nursing Officer, back to risk management strategy. Again, this paper has been considered by audit and politics, so I'll just add the chairs there if there's anything to excavate. They considered this strategy. I'll start with audit. Only anything to
No, I think the paper speaks for itself. We were happy and content with the, were assured by the approach and the outlines provided.
Thank you. Policy.
Not specifically about this paper, Chair, but just to highlight that the Quality Committee has made a decision that it will consider risk risk issues and that earlier in its agenda. Because the feeling that and gets screwed down, and so going forward, we're actually looking at it is a greater priority to recognise that this will drive a lot of the work that goes on with the around quality management and risk. So I think you've endorsed it paper. Yeah, so endorsed it paper. Thank you.
Thank you, Chair. What I need to figure out is just that here, I know, and into those two committees, but I'm quite happy to ask for it. To do the someone will see issues. I'm not going to leave one by one. There's quite a few issues. There'll be one I'm going to pick out. That this strategy is going to sort of reflect and impact on the new hospital program and kind of improve so that we could risks impacted by the capital investment of that current school. So for them, they will include it. So if all is happy to agree, then it's here for final and any question. Thank you.
Only to recognise some of the earlier discussions, Chair, about risk appetite and risk tolerance at the board. So I think we'll get an early opportunity to look for our plan secretary using the principles of the risk management strategy live as we set the back and the plans for next year. And again, very succinct report. My congratulations to the author. We're happy to endorse.
Yep.
Yeah, and agree. Thank you. Item 178, policy and publication reports. Anything to read for attention on? Only specific reports pending, which is the independent investigation into the Great Manchester Local Heritage Foundation Trust issue, which I mentioned at something worth reading, actually. Yeah. Okay, thank you. Item 179, you've got the attendance register, you've got the schedule of business. I've just checked with the company secretary, but no urgent business being brought to our attention. Thank you. I'll end, colleagues. Just if we could minute, please. It's Hugh Reeves' last board meeting as a Ned. His time in term of office now coming to an end. So various other projects and activities which can't be stayed from dawn till dusk. But I just wanted to thank you. I said this because myself and Hugh met last week and went through his experience in the trust and part of an exit discussion. And I said it to you last week, and I'll say it here at the board. He's been quite clear in the 3 years that you've worked with us here, the vast experience that you've gained in your life as chair of the CCG, sorry. Chair of the CCG, the chairs of medical groups and quality groups around Manchester for years. Chief exec, also your own GP practices. All of that experience and skill you report to the trust, and you've been really important. I went into softball and then came out of softball, and your insights and your guidance and your sharing of policy, your contribution as a NED, and your contribution to the board and the council, honestly, it's been outstanding. So I just want to express the deepest thanks to you as the chair, but also on behalf of the board, really. Wish you every success. I know we're going to keep in touch. I know that you're going to do voluntary work in the trust, so any quality issues, assurance issues, I'm sure you will raise and bring to our attention. I'm going to open the floor. I'll ask colleagues to speak. It seems right that the Green could have the next spot.
Just say you, and I've worked with you alongside in the patient experience group and other governors have said back to me that we've always appreciated the fact that you've made sure that we have a clear understanding. And one of the things that I really love about you is your perhaps dislike to strong word acronym. Because I'm very well aware a lot of people got NHS background and experience and really struggle with all these acronyms. And you've always made it very clear and you spoke to them in a language that is just readily, and thank you. You're going to do so much missed.
Is a new teacher who came and did the chair of quality community. So thank you so much for welcoming me. In a way, kind of coaching me into the quality community and how we run the business in there. I really, really liked and valued your honesty and some of what I can call life and and I will really, really miss that. And when you feel like the agenda is too much, you just say it is the things and put it in order and everything. It's been a true coach, you know, that's this is a friend, but very supportive. So I've welcomed that and it helped me to grow into my role at all in managing that quality. Thank you for I'll miss that lesson, but I'll find.
Anybody else want to say anything? Thank you.
Yeah, just I'll echo what the chair said too. So CCG, Bay Health and Care Partners, and here I think at one point you were stalking me. And I think your contribution to the board journey, how play making sure that you've got that natural curiosity to it, the four areas that obviously aren't quite right. There was a legacy that take through the CQI approach, the SPC charts, and so what we do with it. Also stand from either Julianne or Tapper through as important. So a 3-year tenure, but I think you can look back and actually have interaction with them in the future. Big legacy pieces you've had, I think you've had a hand in here to get us onto that next level. So hopefully you can continue to keep going. So I hope that's all. So you're only got a bit of advice and try sensitively where you can, but yeah, you sort of.
Beautiful. I'm going to ask everybody to give a round of applause. Hello.
Want to say anything? Oh, Sakti, thank you.
Thanks,
You're
Chair.
on,
I mean,
Sakti.
Chris, sorry, Hugh and I met during PCT days. I think I'm just counting the number of years. I've admired working alongside Hugh and learned quite a bit, especially from a quality improvement point of view, but also on the Triple Aim program that we worked together, Hugh, if you cast your mind back. And yeah, I just wanted to say a big thank you and really grateful for, although you may not have recognized it, a mentor alongside in a number of ways. So thank you, Hugh, and all the very best.
Last week to you, quite overcome really. So I've been expecting that. 23 years I've actually been involved in up here, so nearly 23 years, right? In August 21 as medical director of the then PCT. So since then I've had leadership roles as well as being a GP, which I wouldn't say only a GP, I say as well as being a GP. Had leadership roles in various organisations that keep changing through the last 23 years. And I was just reflecting with over coffee that Chris and I were reflecting that last because he arrived just after me because the last probably the last 5 years been the most challenging. When I arrived, it was 12 months before I met anybody face to face. Thankfully, I knew quite a number of people, so that helped. But it was 12 months before I met anybody face to face. When I arrived, things that you were not sort of aware of, but weren't aware of the extent of what was going on. So I arrived with the niche inquiry underway, the orthopedics inquiry underway, that CQC assessment that caught us all a bit off field, and that was with a massive challenge, putting us into RSA, and all of that happened within about 36 months of me arriving. I don't think there was no correlation. Right. So we're going to the quantitative correlation, but then 3 years on, I think we just reflect on what we've heard today and how different things are and where the trust is. And again, I don't think there's a cause and effect correlation between mine, maybe there is, certainly Chris is arriving. But I just think this board, and I've been with reflecting with colleagues, not just here, but in discussion with Jeff Jolliffe, who a lot of you will know, yesterday about, I've experienced a lot, been involved a lot of boards, and both as the executive and as non-executive going back into my Stockport days in the 90s. And this is probably the board that I have the greatest respect for in terms of the relationship between execs and non-execs and the way in which the non-execs, the view that the executive have the non-execs, and the fact it feels like a very much a joint board. And I think we just ought not to miss that. We shouldn't lose it, because a lot of boards, there's quite a divide between execs and non-execs, and there's amongst execs, it really don't get stuff through the non-execs, and I haven't had that feeling here at all. But I think that's testament to what's gone on in the trust over the last 3 or so years, and also what I saw during the example of that about how our staff and things are starting to feel increasingly empowered to make changes, to do that other job, just to make their own job. I think I just want to thank you all. You've been a fantastic group of people to work with, and I'll look back on the last 3 years with real fondness. I will probably still have some involvement about voluntary work. I'm not going to actually man the reception. But I have said to Jane, and to Aaron that I'm quite happy to retain some involvement if from a primary care perspective is needed, and I'll do that on an voluntary basis, because that's a sort of using my experience. I'm quite happy to do that going forward, and to retain and to keep my ear to the ground and hear what's going on. So thank you all very much. It's been an absolute pleasure.
That seems a good note. It's closed the meeting 12:50. We'll reconvene as a private board at 1 p.m.
I don't know.